Good morning.
We are already seeing you, so whenever you want, you can start the case telling us the date of the patient. We are together with Bruno Garcia and myself as moderators, and we have Juan Sanchis, Eva Rumiz, Alejandro Diego in the panel.
Yeah, great. Thank you, Tony, for and good morning to everybody. So we are here with Luis Asmarad and the nurse team with Puri, Esther,
and Laura.
And we can start,
yes.
please.
And
we are a very interesting case for you today.
And our fellow Mario will present the case, please.
Okay, good morning, everybody. I'm introducing the case of a 70-year-old male. He is diabetic and is leucemic. His treatment, you can see it on the slide. He's doubly anti-aggregated with Adiro and clopidogrel. And he's having the oral antidiabetics and the statin with ezetimibe, between others. So he was diagnosed from ischemic chronic silent cardiomyopathy in 2020.
Puedes decirlo en español, no pasa nada. No hace falta que sea en inglés.
Bueno, como queráis. Bueno, lo decimos en español, pues. Entonces, le diagnosticado de una cardiopatía isquémica crónica en 2020 a raíz de una ergometría rutinaria que fue positiva eléctricamente. Las pruebas complementarias mostraron una función renal normal, con una hemoglobina normal y un colesterol en niveles objetivo. El electrovasal es esencialmente normal, así como el ecocardiograma. Y se realizó un test de isquemia, un SPEC para detectar isquemia que mostró una isquemia severa anterolateral. Siguiente. La siguiente. Entonces realizamos la coronariografía, en la que, como podemos ver, en el árbol coronario izquierdo nos encontramos con una oclusión crónica total de la arteria descendente anterior a nivel del ostium, con un relleno anterogrado pobre por colaterales septales y una arteria circunfleja no dominante que no tiene lesiones significativas. Como podemos ver, el TAP proximal en la proyección Spider sí que tiene ligeramente forma cónica. El resto de proyecciones, la verdad, que parece bastante raso. Y viene la de atrás. La anterior. Hay que darle al play. Ahí. Vale, aquí vemos la arteria coronaria derecha, que no tiene lesiones significativas. En este caso podemos ver la circulación colateral que aporta desde la arteria descendente posterior, una rama epicárdica de buen calibre que rellena toda la descendente anterior hasta el tip distal de la oclusión, pudiendo ver además dos ramas diagonales de buen calibre, presentando la primera de ellas también afectación severa proximal. Siguiente. Se realizó también un escáner para caracterizar un poco mejor esta oclusión. Y como podemos ver, pues la oclusión presenta una longitud de unos 18 milímetros, con una ligera calcificación endoluminal, y la morfología, como comentábamos que veíamos en la proyección Spider, es ligeramente cónica a nivel proximal. Se repacifica a nivel de la primera diagonal, que efectivamente presenta también una afectación proximal del 95%, y el lecho distal de la arteria es de buen calibre y no tiene lesiones significativas. Así, en resumen, tenemos un paciente con cardiopatía isquémica crónica silente que presenta una enfermedad arterial coronaria de un vaso principal, una oclusión crónica de la vea ostial, sin una ambigüedad proximal en el cap proximal, ya que se ve una morfología ligeramente cónica, tanto en el TAC como en la proyección Spider, con una baja calcificación, una longitud menor de 20 milímetros, con lecho distal del vaso de buen calibre y que presenta circulación colateral fundamentalmente heterocoronaria a través de una rama epicárdica de la posterior lateral. Con todos estos datos, pues me refiero a los panelistas para comentar un poco las diferentes estrategias de revascularización en el caso.
Muy bien. Antes de que Roberto nos diga su estrategia, me gustaría un poquito con el panel ver que, empezando por Eva un momentito, cuál sería tu estrategia, Eva, en este caso, en el que tenemos una CTO del origen de la DA, prácticamente, que con un ángulo muy poco favorable y con unas buenas colaterales desde la derecha. ¿Cómo lo enfocarías?
Bueno, yo creo que es un buen caso, tiene unas buenas características para hacer un primer intento antegrógrado. Yo iría de primeras con una guía polimérica del tipo Fielder XT, y yo creo que es una buena opción intentar buscar un microcanal, y si no, pues sí, intentaríamos una guía un poquito más stiff. De primeras sí haría ese primer intento.
Bueno, ¿algo diferente?
Me gustaría ver mejor el CAP para ver el grado de ambigüedad, porque parece un poco ambiguo, pero aparentemente sí que puede que haya un microcanal. En ese sentido sí que haría un intento anterógrado, pero las colaterales son muy buenas, o sea, posiblemente acabaría retrógrado. Pero bueno, yo un primer intento anterógrado, pero habría que ver bien la geografía para ver el CAP.
Lo que más me empujaría a mí a plantearlo retrógrado es el landing zone y la bifurcación con la diagonal, que están muy pegados. Entonces, teniendo tan buenas colaterales, a lo mejor sí pasaría una guía retrógrada, aunque solamente sea para marcar. Ahí la duda que tendría sería si hacerlo a través de septales, porque tiene esa colateral epicárdica tan desarrollada que por aspecto uno pensaría que hasta tiene muscular, ¿no? Es un puente, ¿no?
Bruno, ¿tú crees que vale la pena primero poner quizá la guía retrógrada para tener un marker que te ayude a hacer el camino del anterógrado? Porque habrá que ir por las dos seguro, pero...
Sí, yo soy partidario de lo que dice Alejandro, porque tiene una bifurcación grande justo en el aterrizaje del final de la oclusión, y lo único es que, ojo, porque la colateral epicárdica, aunque sea grande, es muy tortuosa y a veces o no se tolera bien o es más complejo el paso. O sea que tampoco me empecinaría antes de hacer el intento anterógrado, que es lo que están enseñando ahora mismo.
Okay, we have been discussing, Roberto, a little bit with the panel, so there is a general agreement that to try the antegrade approach is the first thing to do, and maybe with the placement of a wire by the retrograde approach via the septal, to have the guide wire, the retrograde guide wire as a marker, because there is a bifurcation there in the distal cap, so and that may help to make a safe re-entry at the distal level.
Yeah. First of all, it's interesting, Luis, to know that this patient has no symptoms.
Correct.
So because of diabetes, we know that we have many patients with this condition. They can have an ostial LED occlusion without any symptoms. So this is important to know for a clinical point of view. The second point is that we have a CTO of the ostium of the LED with a small stamp, and the distal cap probably is at the level of the bifurcation with the big second diagonal branch. We cannot lose this branch. And so we have an interesting case of CTO crossing. Third point, we need to deal with left main and LED stenting and bifurcation with the SIR. So we have many things to discuss. In this case, we start with putting two safety wire, one on the right in the 2C on blue, one in the right coronary artery, the second one in the circ. We are a biradial approach with 7 French, and we were able to put a Navitian microcatheter for antegrade. You can see here, we engage the small stamp of the ostium of the LED, and we are in this situation. So we have the Navitian here, and we want to start with the bandit wire. So we agree with you that when I have a small stamp, I want to start with the soft polymeric wire just to understand if I am able to follow a microchannel. And if we fail, we will have an antegrade wire escalation with Gaia. So we perform a small bend in the tip of the wire, and then
our guiding catheters are an EVU4 and AL1 for the right coronary artery.
So we will start right now the attempt. We need to know that we have poor backup at the level of the ostium, so we need to be really soft in order to avoid the buckling of the microcatheter once we push the
Just one question, Roberto. the microcatheter that you have placed is a supercross, is a 120 degrees angulated microcatheter or not?
No, we were able to go with the Sion Blue and the Navision.
Okay, it's the Navision, it's a regular one, okay.
Yeah, without any angulated microcatheter. So now we are with the Bandit. I want to
So because it looked like the tip of this microcatheter is very well bent. It looks like a performed microcatheter.
You can see here. Now we want to change. I just try to push a little bit the Navision here. Okay, and then we can store here.
Right now.
Then we want to follow the cranial view to understand if I'm able to look at the Bandit.
Es una Bandit que es una guía floppy. Hemos visto antes aquí el gramaje de la punta, que son 0,8 gramos. Es tapered, se parece un poco a la Fielder XT. Sería la versión floppy de las guías de Teleflex. La progresión bastante buena. Y bien,
So this point
looks nice.
is really important to advance the Navision, okay? So because you can see the bend of a level of the wire, so we have very good feedback with the Bandit, but we need to have more support. So I want to advance the Navision. Doesn't advance too much, so I don't want to force, and I want to try to follow. This is the most critical part, I think, because if I'm able to advance, it will be much easier, but I'm not able to advance the microcatheter. So. Test from the right.
Two.
Yeah, always. Now we need to test always. Need to stay a little bit up. Here we don't want to dissect the bifurcation, because then will be really a problem for us.
Roberto, this is Bruno Garcia. In the angio that you performed when you had the wire that had crossed quite easily, you could see that the distal stump was going, let's say, upper from the landing of your guide wire. So it seems as it was, it was okay until the landing of the bifurcation. Yeah.
Okay, I think that at this point we need to change the wire with the Gaia. Okay, so I don't want to insist with this wire, because we make progress. Oh, sorry, but this wire have a higher risk of dissection, and we know that if we can dissect the distal bifurcation, we will have problem to re-enter in the diagonal branch or in the other vessel. So we want to be safe and not insist. We know that when we have some progression with the wire, but then we go subintimal, we don't need to insist too much with the same wire, because we can increase the dissection. So.
A veces tengo la impresión de que cuando hay tanta curva, el propio microcatéter fuerza hacia el radio exterior, y con la guía ya de entrada ya te coloca subintimal muy fácilmente, ¿no? Entonces, a veces tener un microcatéter preformado que te orienta hacia el centro del vaso, como podría ser el Supercross de 120, en este caso te puede ayudar, ¿no? aunque ahora ya he cruzado perfectamente bien. So,
Stop for, you can see here.
en la diagonal.
Do you want to replay?
We do yeah, we can see the replay.
Yeah, absolutely.
You can see the difference between the bandit make the first part and then changing with the Gaia. It makes the difference at the level of. We discussed with Luis before. I told him, I'm sure that I will go in the diagonal branch, you know. And in fact, this is what happened.
Do you plan to use a dual lumen catheter now?
Yeah, because when you have this kind of bifurcation, the Gaia, the CTO wire always go in the diagonal branch. So here we need to advance the Navision. We change with the Sion wire, and then we will take a dual lumen.
At that point, it is important also to be sure that the bifurcation is preserved, that you are not in a subintimal track at the bifurcation.
Yeah, this is a very important point, and we will see the behavior of the wire. Now I want to advance the Navision, but I don't want to force in the left main, but we need to.
Which wire are you using now?
Was a Gaia second.
Gaia second.
You can see the support is not too much.
You are very good.
Okay.
Very nice.
We're able, because in this situation, dilating with the balloon can be a problem for the bifurcation. So I want to avoid, if I can, the dilatation. So we're able to advance the Navision. So the performance was very good of the microcatheter. Okay. Now we need a trapping balloon. So we put a Sion wire in the diagonal branch, and then we will prepare a dual lumen.
Yeah. Esther, value de 2,5 per trapping?
We have a twin pass.
Yes, we do.
Okay, so. Okay.
Do you want trapping or with injection?
No, trapping. Trap always.
Okay.
Always remember you need to trap. Don't do the injection because you need to have a fixed position of the wire. So.
Sí.
Yeah.
Sí, sí.
With 7 French, we can do trapping with 2-0 balloon or 2-5. It's the same. But always do trapping balloon.
So which is the next step, Roberto?
So in our mind, we want to use a dual lumen, and then we need to understand. We can check again from the left, from the right, so from the injector. Yeah?
The only yeah.
Now look at the bifurcation. So we have in this situation, I think that we need to puncture the LED, and normally I use the ultimate bros 3 in this situation. I don't use anymore the ultimate bros for classical CTO crossing, but I use in this situation because I think that, as you can see, we have something to puncture at the level of bifurcation of the LED. And the other possibility is try to use a Sion very carefully, and if the bifurcation is open, we can cross with the Sion. Otherwise, we need to go with the ultimate bro. So I asked to Luis, which is his preference in that situation, and we can do both. We can start with try with the Sion, very soft, and I think that we will not able to cross with Sion, and then we go with the ultimate. Okay.
Sure. Perfect.
So dilate the trapping balloon. Okay,
Okay.
the pressure is okay. We can remove the navigation.
Guardas el-
Perfect.
Okay.
Okay.
Which catheter are you using now?
The twin pass
Twin pass.
for dual lumen. So,
Yes.
okay. The Shapimulu was an experienced pro or not?
Experience Pro. Yeah. Tens aquí.
Perfect. So we go to with the trapping with the twin pass, and then may I have a regular Sion for the attempt to cross. So this is a classical dual lumen. You can hold the wire, hold the Sion blue. Perfect. Then okay, a little bit like this.
Yes. Començarem amb una Sion.
So here is important to check from the right the position of the dual lumen, because we don't need to go too distal.
We are a bit too distant.
We are a little bit too much, so we go back
Okay.
a little bit, like this.
Good.
Okay. Then we go with the Sion.
Yeah.
And then if we fail, we go with the ultimate cross.
Roberto, maybe I'm wondering if you advance a little bit more the twin pass, and then you exit the proximal wire and you come back, maybe it will be easier to enter at the LAD.
Yeah, we will do that. This is a good suggestion.
Maybe with a pre-bended guide wire, in the retro bend, in order to catch the proximal LED, the medium LED, with a Sion pre-bended. Huh?
Yeah, so Alejandro suggests that, I mean, probably you will perform extra bending for the Sion, but if it does not succeed, even doing a hairpin technique, the wire completely bended into the diagonal to catch the LED.
This is, I think, the most interesting part of the case. So check from the right.
We are still.
You can see here we are probably too proximal. I try to go a little bit distal with the dual lumen. Okay, we're in the diagonal. Now, check.
It is interesting because we were, well, in the previous session they were commenting that we need to deal with, good, that's good. We need to deal with calcified lesions, but also with bifurcated lesions. So, I mean, the CT operator has to be the perfect operator.
So film. No.
Approximately.
I think we can try to increase the bend,
Sure.
and then we decide to change to go with the ultimate bros to punch. Because I think that we have, when you enter with the Gaia, and then we will see by IVUS, many situations you go subintimal and you enter distal to the bifurcation. So in this case, you really need to do something different.
Another option, Roberto, is once you are into the diagonal with this second wire, you pull back the catheter and then you try to catch the LAD without having the catheter so close, because the catheter is not in phase, and when you advance it, the tip of the wire is not pointing downwards, but is pointing upwards. So if you pull back a little bit more the catheter, then you have the wire free to rotate, and maybe it's going to be easier to catch the LAD.
Yeah, because also you can see the exit of the twin pass is here. Check. Now we are.
That's it.
Test.
Good.
Seems better.
Mm-hmm.
Yes.
Yeah, definitely.
Okay, very nice.
Okay, good. So you see that it was a problem of having the good position of the dual lumen and the bend, the correct bend of the wire, so much better. So we did the perfect puncture also in the diagonal. This is very good for the patient. So we can go trapping balloon again, and then we can do the evaluation. We can dilate with 2-0, and then we can do IVUS, and we decide together the best strategy.
Perfect. Steph, Barbados. No.
Luis, did you save the fluoro?
Yes, sure.
Can you just to check how did he cross?
I think it was essential the concept we discussed with Tony to go a little bit distal with the twin pass.
This made the difference, yeah.
Normally, you go in the level of bifurcation proximal, but in this situation, if you are too proximal, you are in the middle of CTO, and the Sion will never enter.
Bueno, necesitaré espera.
Okay, inflate.
Okay.
Perfect. We remove the twin pass with the trapping.
Okay.
Great. We remove the trapping balloon.
And we go with the 2-0 balloon.
Yeah, I think. So 2-0 balloon in the LED.
Tens, Barbados.
And then IVUS.
We have it ready. Yeah.
Which one is the balloon?
It's the same Experience Pro.
Okay. 2-0.
215, yeah, 2015. Hold on. Okay, I got the wire.
Okay.
Okay. Nice.
Great. So you can dilate from here. Okay, deflate. Here. Deflate.
Okay.
Yeah, inflate here. Okay, deflate. So IVUS.
Okay. Ibus? A 12. Digue-li si estan Marcelo o Estefania per l'Ibus, porfa.
Creo que el eco es importante, el IBUS es importante para ver cómo está el ostium de la DA, ¿no? Y ver si se puede enrasar el stent o no, o hay que llegar hasta el tronco. Esta creo que es la decisión más importante, ¿no? Y el motivo de poner el IBUS en esta lesión. Si no fuera así, probablemente no haría falta. Es una lesión que ya hemos visto en el TAC, que no tiene calcio y por tanto se tiene que comportar bien con el stent.
Actually, our idea was to cover, to do a provisional left main LAD. Actually, because in the CT there is some...
You can do ring down.
Yeah. In the CT there is some plaque, some moderate plaque in the distal left main.
Yeah.
We will confirm now.
Pero si no tuviéramos el CT, ¿no? En este caso, el eco, el IBUS es el que nos daría esta clave, ¿no? De estentar o no el tronco.
So this is the IVUS.
Vale.
So from here.
Okay.
Okay. Registra.
Graba?
No,
Okay, no.
It's coming the diagonal branch at 6 o'clock. You can see here.
Mm-hmm.
The bifurcation is free. Perfect. A lot of plaque without calcium, at what the CT scan was explaining us. And then this is the circ. The ostium of the circ is good, so I think we can go for a provisional stenting.
Sure.
Okay, I think we need to have two different stents because we have two different size at the level of the diagonal and the bifurcation. We can see again the IVUS, and we can make some measurement. I think that
Can you replay the IVUS, please?
we need to put no more than 2.5 distal to the diagonal branch, if you can see.
¿Podéis medir?
And then at 3.5 at the level of left
I
main.
think so, yeah.
What do you think? Tony, which is your suggestion?
Yeah, maybe you can adjust the stent, the distal portion of the stent, just at the bifurcation, if you want to use only one stent, because I guess that in the first angio, there's a little bit of LAD that seems quite normal before the bifurcation.
Now we think we need to stand distal to the diagonal for sure.
I mean, the question is, do you need to stand the LAD down to the origin of the diagonal, or maybe you can adjust the stand just at the bifurcation?
No, I think that we need to stand distal.
Across the diagonal.
Yeah. We need to stand across the diagonal, and then I will take it to 5, not too long,
And then,
a 3.5.
Yeah.
And are you planning to use a single long stand or 2 or 3 stands?
No, we want to use two stands. Okay, so
To 515 is okay for you?
or even 20, more, a little bit
Longer?
Yeah, longer than 15, because I want to be sure to go proximal to the diagonal with the. And so we can measure also the other stand.
Casi medio 20 o así.
So you plan to use first a 2.5 short one and then go to 3.5?
Yeah.
Because that stand that you will implant will be an angiolite, yes? Is that
Yes, correct.
Yeah, will be an angiolite.
Yeah, the 3.5 you can post dilate it up to 5 and something.
Yeah,
So it's a good stand for this special situation where you have mismatch between the LAD and the left main. So it allows you to overexpand the stand like other stands. For instance, the Tansei. I mean, it has a similar behavior.
And so you plan a provisional stenting in both bifurcation, in left main and diagonal and LED?
Exactly. We want to. We put a stent distal to the second diagonal, and then we put a stent left main LED provisional to the circ, because we have. If you go back to see the IBUS again, we have the circ that is open. So can we see the IBUS again? We will show you from the beginning. Okay, play. So this is the distal LED. It is a small one. Probably is also under perfused. Then here we have if you stop here, okay, and we can do a diameter evaluation of the. So we have a diameter that is 2.5. Okay, play. Play again. So 2.5 is good for the LED. Then we have the diagonal here. The bifurcation should be nice. Then we go to the proximal LED. You can see here that the plaque the vessel is size is good. It's 3.5 at least. So we need a good stand. And then here you can come at 4 o'clock. The circ, play. Stop. This is the carina, the bifurcation between ostium of LED and ostium of the circ. So I think that we have the plaque that is opposite to the ostium of the circ, of the carina. So I think that with IBUS evaluation, I'm quite sure that we need only one stent in the left main. Probably we don't need also kissing balloon. We need only to put a stent and post dilate. But we will see with the angio. So we can have a stent.
Yeah.
Where some delay
2.5
in the stent, but we will find. And going playing it, see the left main. Okay, perfect. Then we have stop. You can see that the IBUS have the distal part of the left main have disease. So play. So this is stop. A little bit back to evaluate the size of the left main. Back. More. Okay, stop. We can have the diameter is 4.6. So we have a big mismatch between.
Yeah, it's nice. I mean, with a 3.5, no problem to push up to 5.
You don't have to fight.
It's too much.
Yeah, for that.
I think, Roberto, that in the angio you saw that the left main has a tapered shape, let's say. So you don't need to stent all the left main probably, just to keep on the, on the 4.0
Yeah.
or 3.5 diameters of the medium left main, let's say.
Yeah, I agree. We need to put the stent, but we need to cover the distal part of left main. We have seen also with IVUS that we have some plaque, but not the ostium. No.
And we go with a longer.
Okay. So we put 2.5/18, and then we go with 3.5.
While you are doing that, can I ask you a question about the CTO? Just in case, imagine that you should need to go retrograde. What collateral have you used?
Yeah, this is interesting. I can show you this angio because we discussed with Luis. You can see that we have 3 different connections. One that for me is completely forbidden is the epicardial to the apex, because you can see it's very tortuous at the beginning, so you have high risk of not crossing, of complication of and ischemia. So avoid this epicardial. The second connection is the septal in the mid of the PDA that seems better in the angio in the previous angio. Now you can see that it's quite tortuous and can be not easy to cross. The third, and for me is the most favorable, is the one that is the more proximal, you can see. But interestingly, this kind of septal arise not from PDA but from the small branch. So if you can see here coming the small branch and then the septal. So this is if I had to do retrograde, I will search for that vessel as a first collateral. Yeah.
Okay,
So
thank you.
You're welcome.
You won't use it, but we will learn from you.
Oh, it's interesting because you need always to check very, very well the angio, because I made some mistake in the past in case like this, searching every kind of a connection from the first septal to the PDA, and then after 1 hour of attempt reviewing carefully the angio, I've seen the same connection that was from a small vessel, and in 10 seconds you can cross. So this is really important, a good important message. So I think we can go here.
Okay.
Okay. Like inflate. Stop. Don't move the. Okay. No. I said to the patient that was moving.
Okay.
Okay. Deflate. So we have inflate here. This is 18. We need to go with the bigger, with longer.
Larger, no? Yeah, longer. Okay.
Deflate. So this is 18.
Luis, esto es el balón, ¿no? Solo.
No, this is already the distal stent.
Inflate. So which line we have for the 3.5? Okay, this one.
2.5 por cuánto, Luis?
18. 2.5-18 ahora iremos con el 3,5 más largo. Angiolite da 3,5, una mica més.
So we're waiting for a angiolite 3.5, more than 30, I think.
El 3 i el 19, serà el 24.
So you will put the 2 stents with the trapped wire on the diagonal? Is that the plan?
Yeah, yeah, yeah.
3524. Is that
It's
okay?
short, longer.
Short, longer?
Yeah.
Okay, then 29.
The longest you have? Okay.
I think could make the job.
Yeah.
29.
I think that we have some risk to be a little bit short in the
Okay.
left main, but
Is there anything longer than 29?
just to evaluate, because we need to be. I think we can remove the system from the left, from the right, just doing a short angio to be sure that we have no problem on the. Okay.
Okay, it's perfect.
Perfect, because we have no more collateral, so we can remove everything.
3529 is the longer we have.
Okay.
The longest. Okay, go ahead.
And we have some
Oops. Okay.
something.
Tenim un...
El panel, ¿dejaríais la guía aquí y pondríais el segundo stent y dejaríais la guía en la diagonal o la retiraríais, la guía de la diagonal, antes de poner el segundo stent?
Yo haría
Por si acaso.
Haría un pod proximal y la retiraría.
I mean, Roberto, regarding the wire in the diagonal, the panel thinks that I mean, it will be more secure if you pull out the wire of the diagonal before inserting the second stent. Maybe you can do a small injection now integrately to check that the stent in the LED is nice, and then pull out the wire from the diagonal.
But we can leave it, no problem. So we have angiolite 3529, right?
That's it. Okay.
I'm not sure will be enough, but let's go to see.
Okay. Posar el Symvision.
I think we need to.
You can look here how much overlap you are. Okay.
Okay.
No contrast.
I think we need to go here.
I think it's okay.
Right, let's go. Inflate 10, 12, no more than 12.
Okay. 12.
Okay. Okay. Deflate. Then we can do an angio. We can switch from the manual injector to the
we'll do so.
mechanical one.
Aquí un comentario que ha hecho, me parece, es Eva, sí. De hacer el pod, cuando tienes un segundo stent mucho más grande, aprovechas, lo avanzas un poquito, es el pod barato, digamos, el pod catalán. No lo avanzas hasta la bifurcación, dilatas. Manolo asiente, eso le ha gustado. En Córdoba también lo aplican.
Sí, el tema es si había alguna
el pot económico.
poner el stent justo en el ostium de la DA sin invadir el tronco. Creo que no lo he hecho porque había un poco de placa en la bifurcación, pero no había mucha placa.
Había más placa en el tronco distal que en la bifurcación, me parece. O sea, antes de la bifurcación.
Yo hubiese cubierto el tronco.
So, we have.
Era mucho bisel.
Was perfect. 29 was.
Yeah. You want to repeat that?
Yeah. So we can remove the wire now on the diagonal branch.
Distal al stent.
Okay. So without any problem. Now we can. I think we need to post dilate the left main with the 4O.
NC da 4, Esther.
So we post dilate the.
Want to repeat the answer? Show us the answer again. Previous one. This.
We can remove also the wire on the circ.
Is there any issue distant to the distal stand?
So we have only one
Okay.
wire, and we can. You want to repeat again the angio?
Yeah, just to check the distal edge of the stand, is it?
Yeah, you see, it was a 2.5 and
A bit big.
Can we check with IVUS the final?
We'll do so, yeah, we are preparing that.
we want to do a pot on the level of left main, and then we will check with IVUS for the LAD. Okay, we have 4.0,
Yeah, it's coming.
non-compliant.
Bernie, después vuelve, que te necesitamos.
Sí.
It's a non-compliant experience
412, non-compliant.
Perfect.
Yeah.
4.0. So we can dilate well
Sure.
the stent.
Sí, really. Okay.
Then we can go also to 20, 25. No, we have
27.
27?
Yeah.
Okay, you want to do?
Okay.
Okay. Check a small test on like this. Like, wait a little bit.
Tenim el Simvision?
Okay, here. 10, 12, 14.
14.
Deflate.
Después de este caso, volveremos a conectar con Dublín. Nos van a enseñar cómo ha quedado al final
16, 18.
el estén en el tronco, igual que este, más o menos, ¿no? Para ver el resultado final.
18.
20. Okay.
20.
Deflate. Okay, we can check by IVUS.
Mhm. Sí.
We can do some nitrates, but the pressure is not so high, but we want to do some
Sure.
small injection.
Okay.
How much?
And IVUS, please?
1 cc.
1 cc, 1 cc, yeah. ¿Dónde?
Okay.
Okay.
So we will see with IVUS the distal part of the LED of the stent in the bifurcation and the apposition of the stent in the left main and the proximal LED. Okay,
Do you have wire?
leave the yeah.
Yeah. Okay.
Okay.
Yeah.
We can do
okay.
ring down here.
Yeah.
Okay, perfect. So we are okay, recording.
Graveu?
So here we are at the level of distal to the stand, the edge. 45 is perfect. Okay, stop. What do you think?
Looks good.
Also, the distal to the stand
Yeah,
looks
I didn't
good.
see
The small plaque, probably we can stay a little bit 1 millimeter distal, but
probably.
okay.
Yeah, Roberto, I think this is a fantastic result. Huh? Congratulations.
Thank you.
Roberto, nice case, very educative. Thank you very much. We have learned a couple of things very interesting in that case. Thank you very much, Roberto and Luis, and all the team of the Hospital de Sant Pau, all the nurses and all the people working, and fellows, and all the people working with us. Thank you very much.
Yeah, it was a really pleasure for me to be here with all your team, so thank you. It was great.
Thank you. Bye-bye. Arrivederci.
Bye-bye.